shoulder anomalies, absent collarbone complaint. The parents discover, usually within their child's first 2 years of life, that one or both collarbones are entirely or partially absent. Assessment. Absence of the clavicle can be felt on palpation. In addition, there tends to be a noticeably large forehead with widely placed eyes and a relatively small face. The chest is narrow and the shoulders hang. The anomaly may be unilateral or bilateral. A part of the clavicle may be absent, or the medial as well as the lateral part. But sometimes the entire clavicle. When the abnormality is bilateral, protraction of the shoulders is sometimes such that the shoulders can be approximated on the front side of the body. Fig. 5.1. Disability is minimal. Diagnosis: cleidocranial dysostosis. Explanatory note: cleidocranial dysostosis. Heredity plays an important role here. In 2/3 of cases the anomaly is familial, autosomal dominant hereditary. The anomaly is as common in boys as in girls. In addition to the absent clavicle, other abnormalities may be present, such as a large forehead with a small face, a widened nose, hypertelorism, a small chest, and sometimes repeated voluntary shoulder and elbow dislocations. X-rays can show short and pointed distal phalanges of hands and feet. An extra epiphysis may be present in the proximal part of the metacarpal and metatarsal bones 2 to 5. In a large number of cases, hip abnormalities such as coxavara may be present. Fig. 5.2. Children with this condition usually don't become tall. Boys reach an average height of 156 centimeters as adults, and girls 144 centimeters. Supplementary assessment: X-ray of the clavicle to confirm the diagnosis and an antero-posterior X-ray of the pelvis to either show or rule out a coxavara. Primary care treatment: do not forget to request an antero-posterior X-ray of the pelvis. When to refer: only when there is irritation of the brachial plexus. This may occur even if the clavicle is partially present. Also refer if there is a coxavara. Secondary care treatment: cleidocranial dysostosis. Operative removal may be necessary if there is irritation of the brachial plexus due to a partially present clavicle. Elevated shoulder blade complaint: one shoulder blade is higher than the other. There is a more or less noticeable swelling above the collarbone. Assessment: one shoulder blade is higher than the other and is rotated, and the upper edge of the shoulder blade projects above the collarbone. The shoulder blade is smaller than normal. Abduction of the involved shoulder tends to be limited. Fig. 5.3. Diagnosis: Sprengel deformity. Explanatory note: Sprengel deformity. This anomaly is usually unilateral. In 70% of cases there is another congenital abnormality present, such as scoliosis, kyphosis, torticollis, Klippel-Feil syndrome 1 or Poland syndrome 1. The deformity develops because in the second fetal month no distal migration of the shoulder blade occurs. Normally the scapula falls to equal levels between the second and seventh thoracic vertebrae. The deformity varies in severity. The affected shoulder blade can be 1 to 12 centimeters higher than the normal contralateral side, with an average of 3 to 5 centimeters. Abduction is limited because of the rotation of the shoulder blade. However, in about 1/3 of cases there is also a bony connection between the shoulder blade and the 4th to 7th cervical vertebrae known as an omovertebral bone. Fig. 5.4. The severity of the limitation movement varies considerably. Supplementary assessment: X-rays of the shoulders and additionally a CT scan or MRI to visualize an omovertebral connection, often difficult to see on a standard X-ray. Primary care treatment: none. When to refer: when abduction is less than 120 degrees or if there are cosmetic issues. Secondary care treatment: Sprengel deformity. No treatment should be carried out in mild cases with an abduction of 120 degrees or more and if there are no cosmetic objections. Only if the abduction is less than 120 degrees, operative reposition of the shoulder blade will be considered. If the upper edge of the shoulder blade will project far above the collarbone, but there is still a good abduction, resection of the supraspinous portion of the scapula may be considered. In severe cases where the elevation is more than 5 centimeters, it is better to perform the operation in the first year of life. The operation can be performed between the ages of 3 and 8 years in less severe cases with an elevation between 3 and 5 centimeters.